Hi, I will be discussing Case 3 and Case 4 of our Unit 4 Case Connections assignment. In Case 3, we have a 47-year-old man who presents with pain in his big right toe, and we have to explain why he has gout. Essentially, gout is the asymmetrical monoarticular inflammatory arthritis of the small peripheral joints caused by deposits of microscopic crystals. The American College of Rheumatology created a diagnostic criteria for the presentation of gout, with which this individual has at least 6 clinical findings, all related to the pain in his right toe, also known as the first metatarsophalangeal joint. Hyperuricemia is high levels of uric acid present in blood serum, defined as a value of at least 6.8 milligrams per 100 mLs, and this man has 10.5 milligrams. Uric acid is the end product of purine metabolism, which is excreted in our urine and the precipitating factor for gout. Other risk factors for gout include being male, hypertension, hyperlipidemia, diabetes, trauma, alcohol use, consumption of fatty foods, purine-rich food like red meat, organ meat, and seafood, and also sugary drinks. Gout can result from inborn errors of purine metabolism, or the overproduction of uric acid, or the undersecretion of uric acid, and it seems this man's case is likely the undersecretion of uric acid. Of course, more diagnostic testing is needed. For example, he needs a sample of the joint or the tophus to be visualized under polarized light microscopy to confirm the presence of monosodium urate crystals, which are needle-shaped and cause the acute inflammatory response in the joint, called acute gouty arthritis. MSU crystals can form nodular masses in soft tissues, and these nodular masses are called tophi and can progress to chronic tophaceous gout. The analysis of the fluid joint is also necessary to rule out septic arthritis, which is an emergency. Overproduction of purines is a less common cause of hyperuricemia, likely to be caused by gene mutations, malignancies, tumors, chemotherapy, and we'd need to know more about this man's family history and medical history to determine that this is the cause. Conditions that encourage the proliferation and the subsequent death of cells, also known as cell turnover, such as psoriasis, hemolytic anemia, myeloproliferative disease, tumor lysis syndrome, and cancers treated with chemotherapy can increase purine metabolism and cause hyperuricemia. But just because you have hyperuricemia does not mean you have gout, and hyperuricemia alone cannot diagnose gout. Mutations in the gene for X-linked 5-phosphoribosyl 1-pyrophosphate synthetase, PRPP synthetase, can lead to PRPP synthetase superactivity and the overproduction of purines and uric acid. Mutations in the PRPS1 gene decrease the regulation of the PRPP synthetase enzyme and increase the production of PRPP. It also decreases sensitivity to allosteric inhibitors like purine nucleotides. Genetic mutations, however, would typically appear in infancy or early childhood and cause developmental delays and neurological problems, including weak muscle tone, impaired muscle coordination, and hearing loss. Even glycogen storage disease, like Cori or von Gerke's disease, a deficiency in glucose 6-phosphatase, can cause hyperuricemia, leading to gout. A deficiency in glucose 6-phosphatase leads to the accumulation of glucose 6-phosphate, which is diverted from gluconeogenesis to the pentose phosphate pathway. Increased pentose sugars lead to an increased synthesis of PRPP and increased synthesis and degradation of purines, thus increased uric acid. Again, this would be diagnosed in infancy or childhood. Lesch-Nyhan syndrome is a deficiency in hypoxanthine guanine phosphoribosyltransferase, HGPRT. HGPRT deficiency is also an X-linked genetic disorder. Decreased salvage of hypoxanthine and guanine and increased availability of PRPP leads to the overproduction of uric acid. A unique clinical finding of Lesch-Nyhan syndrome would be self-injurious behavior that emerges around 2 years old. These examples of inborn errors of purine metabolism and conditions resulting in the overproduction of purines are probably not the cause of this man's gout. Undersecretion of uric acid by the kidneys is the most common cause of elevated uric acid in the blood. Nephropathy, lead poisoning, alcoholism, drugs like thiazide diuretics, ketoacidosis, lactic acidosis can all cause the undersecretion of uric acid. Unless we know the patient's medical history, there's no way to know if an individual's kidneys were damaged first, or if the high uric acid secondary to another condition damaged the kidneys. As I mentioned before, diet is a major risk factor for gout. Regular soda uses high fructose corn syrup, and fructose elevates uric acid levels in the blood. Drinking soda would make this individual's gout worse. Fructose metabolism requires adenosine triphosphate, ATP, and when one ingests a lot of fructose, its conversion to fructose 1-phosphate by the enzyme fructokinase uses a lot of ATP and depletes the cells of their phosphate, which activates AMP deaminase. AMP deaminase converts adenosine monophosphate to inosine monophosphate, or IMP, which is further metabolized to xanthine and the end product uric acid. In addition to elevating uric acid levels, ingesting a lot of fructose stimulates fatty acid synthesis, and long-term ingestion of too much sugar can lead to weight gain, hypertension, hyperlipidemia, and these are all risk factors for kidney damage and gout. So yeah, don't drink a lot of sugar. He should stop and improve his diet. In case 4, we have a 58-year-old woman who presents to the emergency room with fatigue, weakness, diarrhea, numbness and tingling of her extremities, tachycardia, a beefy red tongue, a beefy red smooth tongue, a murmur, and low hematocrit. She has megaloblastic anemia, it seems. But we need to discuss why the vitamin deficiency, or which vitamin deficiency is likely. So we have iron, B6, and B12. And iron is obtained through our diets, and is an important part of the heme component of hemoglobin in blood and myoglobin in muscles. Iron is used to synthesize collagen and neurotransmitters. It's stored as ferritin, and actually men are able to store more iron than women. And an iron deficiency caused by low intake or bleeding leads to a reduction in red blood cells. Some symptoms that are consistent with the iron deficiency in this woman are her tachycardia, pale conjunctiva, her shortness of breath, fatigue, weakness, and low hematocrit, because these are symptoms found in someone who may be bleeding or hemorrhaging. But iron deficiency doesn't explain her beefy red tongue, her decreased sensation to touch, and although she has mild diarrhea, she doesn't have black or bloody stools, so she probably doesn't have a GI bleed. Vitamin B6 is also an essential water-soluble vitamin that we obtain through our diets, and it's a cofactor in many metabolic pathways like gluconeogenesis and glycogenolysis. Enzymes involved in the synthesis of nucleic acids, heme, neurotransmitters like serotonin and dopamine are also dependent on vitamin B6. It's also used in the tryptophan kynurenine metabolic pathway, which regulates immune response and inflammation. Deficiency in B6 is rare, but is related to malnutrition as well due to impaired GI function and liver dysfunction, whether it be by alcoholism or drugs. Symptoms of vitamin B deficiency include seizures, changes in mental status, rashes, cheilitis, scaly lips, and a smooth swelling tongue. Depression is also found with severe vitamin B6 deficiency, but other than the tongue swelling and some of the neurological changes, this woman's symptoms are not as aligned with vitamin B6 deficiency. I say this because this woman presents with some of the most notable symptoms of vitamin B12 deficiency, like muscle weakness, numbness in the hands and feet, fatigue, loss of balance, diarrhea, tachycardia, and the smooth, beefy red tongue. Megaloblastic anemia is characterized by abnormally large red blood cells called megaloblasts, which are found in bone marrow. B12 is an essential vitamin, and it is used for the synthesis of succinyl-CoA. And succinyl-CoA is the intermediate in the TCA cycle. It's a cofactor that works along with the enzyme methylmalonyl-CoA mutase, which is involved in the metabolism of fatty acids with odd number carbons. It's also a cofactor of methionine synthetase in the metabolism of amino acids, converting homocysteine to methionine, an amino acid that gets broken down to succinyl-CoA. Propionyl-CoA is a product of fatty acid metabolism and is further metabolized as succinyl-CoA. Propionyl is carboxylated to form D-methylmalonyl-CoA, which is then isomerized to form I-methylmalonyl-CoA. And finally, the carbons are rearranged by methylmalonyl-CoA mutase, requiring adenosylcobalamin, a derivative of vitamin B12, to form succinyl-CoA, which is now able to enter the TCA cycle. Methionine is converted to S-adenosylmethionine, or SAM, using ATP, and after donating its methyl group, it becomes S-adenosyl homocysteine, or SAH. SAH is hydrolyzed to homocysteine and adenosine, and from here, homocysteine may become methionine or enter the transsulfuration pathway and become cysteine, as long as quantities of methionine are adequate. Homocysteine's conversion to methionine requires the derivative vitamin B12 called methylcobalamin. Homocysteine takes the methyl group from N5-methyltetrahydrofolate, and in a reaction with methionine synthetase, which requires the methylcobalamin, produces methionine and tetrahydrofolate. Tetrahydrofolate is necessary for purine nucleotide synthesis because it's a source of atoms in the formation of purine rings, which are used in RNA and DNA synthesis. And without vitamin B12, these products are reduced. Vitamin B12 deficiency decreases purine synthesis, and vitamin B12 deficiency would halt these two pathways and interrupt the TCA cycle and lead to metabolic acidosis, neurological dysfunction, kind of like the symptoms this woman exhibits. A complete blood count, a CBC, and a peripheral blood smear would show hemoglobin, hematocrit, decreased red blood cells, white blood cells, and platelets, and a red blood cell mean corpuscular value, an MCV, and a red blood cell distribution width would also be elevated, which is consistent with enlarged red blood cells or cells of different sizes. The peripheral blood smear would also show oval macrocytes, which are larger than normal red blood cells, and hypersegmented neutrophils and Howell-Jolly bodies. Bone marrow aspiration would show myeloid cells, megakaryocytes, and an endoscopy or a colonoscopy might